Every practice administrator knows it, but rarely says it out loud. When staffing gets tight, modifier compliance is the back office task that gets ignored. And that is exactly where legitimate practice revenue quietly disappears. The 2024 CMS Medicare fee-for-service improper payment rate stands at 7.38%. That represents $31.2 billion. A significant portion traces directly back to incorrect coding and insufficient documentation, the exact categories modifier compliance is built to control. Zoom out to the entire healthcare industry, and physicians lose an estimated $125 billion every year due to claim errors and inaccurate coding. That averages out to roughly $5 million lost per provider. For a standard 3 to 4 provider practice generating $3 million annually, that translates to between $120,000 and $150,000 a year going uncollected. The services were delivered, but the back office could not keep up. Proper modifier compliance secures the cash flow your providers have already earned. It protects the bottom line from avoidable administrative leakage. Revenue loss hurts, but modifier misuse carry a much heavier penalty. Federal oversight has quietly intensified. This logic tree details a recent Office of Inspector General audit. They tracked Medicare payments for intravitreal eye injections billed alongside a same-day evaluation and management service using Modifier 25. When reviewed, a staggering 92% did not satisfy the requirements. The OIG now uses advanced data analytics to pinpoint these outlier modifier patterns down to the exact practice level with startling precision. Systematic modifier misuse creates serious exposure. It can trigger False Claims Act liability, bringing with it trouble damages and heavy per-claim penalties. Ignoring modifier compliance transforms a standard back-office bottleneck into an active legal and financial threat for the practice. People who have never worked in medical billing assume the process is straightforward. Apply a code, attach a modifier, and send the claim. But the daily reality is highly complex. Consider a pain management practice. They deal with high-complexity modifier logic constantly. Bilateral procedures require Modifier 50. Distinct procedural services need Modifier 59. Each carries payer-specific audit scrutiny. This flowchart highlights the core operational friction. The rules are not consistent. A modifier application that clears Medicare today might be blocked by a regional Blue Cross Blue Shield plan tomorrow, requiring a clinical note addendum that did not exist 6 months ago. When pain management practices attempt to handle this logic in-house without dedicated specialists, their denial rates jump to between 20 and 25%. This friction is accelerating across the industry. Initial claim denial rates hit 11.8% in 2024, up steadily from previous years. The sheer volume and volatility of payer rules make it mathematically impossible for generalized, untrained staff to maintain clean claim rates. When denials rise, practices typically try to solve the problem by overwhelming their current staff or attempting to hire dedicated in-house coders. This diagram illustrates the financial burden of the in-house model. Hiring a dedicated modifier specialist costs between $55,000 and $75,000 a year once you factor in salary, benefits, and the inevitable cost of turnover. The alternative is a generic offshore BPO, but they utilize shared staff pools. The people handling your queue never actually learn your specific practice workflows. This creates severe inconsistency. A modifier applied correctly one week is missed the following week because a completely different person is processing the claim. The appeals process drags out. Consequently, 35 to 40% of insurance claims extend beyond 90 days, locking in heavy write-off rates of 8 to 12%. Practice owners are trapped choosing between financially draining in-house overhead and operationally disastrous generic outsourcing. There is a targeted solution to this dilemma. Smart practices are outsourcing this workflow to dedicated AAPC certified specialists who connect directly inside the practice's EMR. Companies like Staffingly provide dedicated seats. These are not shared pools. The same credentialed coders work your queue daily and are accountable to weekly key performance indicators. Instead of absorbing a $55,000 in-house burden, Staffingly's model is roughly $20,000 annually. It layers AI-augmented smart routing over human expertise, prioritizing the audit queue by payer risk level and claim value. This combination of AI scrubbing and human clinical oversight routinely keeps error rates below 1%. Trading physical office oversight for a specialized EMR-integrated EMR offshore team solves the operational nightmare for the billing manager and the financial risk for the owner. For most practice owners, the final hesitation comes down to data security and the friction of setting up a new workflow. The security posture is rigorous. Teams operate under HIPAA, SOC 2 Type 2, and HIT-REST frameworks before they access a single file. Implementation is rapid. It starts with a kickoff call, establishes a secure connection within 48 hours, and gets your team live in 14 days for a pilot. You see measurable ROI within 60 days. Leaving modifier compliance as a deprioritized back-office task guarantees continuous revenue leakage and leaves your practice exposed to escalating audit risks. Stop the financial hemorrhage. Book a free 30-minute strategy call today to evaluate your current setup and start capturing the revenue your practice earned.